There have been a couple of studies that have been published on the use of plasmapheresis in myasthenia gravis. The first one is by Gajdos in 1997, in which patients with severe myasthenia gravis, those in crisis that is, have been treated with either plasmapheresis or IVIG. In that study, there were 87 patients, and both groups treated with either modality or the other responded well to that therapy. Since then, there's been another study in 2011 by Barth and colleagues, in which 84 patients were randomized to be treated with either plasmapheresis or IVIG. These were patients with moderate to severe myasthenia gravis, as evidenced by a QMG score over 11, and they were worsening, and there was no difference in the improvement in the QMG score between both groups. In a follow-up study in 2013, in addition to the QMG scores, the same authors published quality of life data showing that the quality of life improvement is comparable between plasmapheresis and IVIG. Therefore, there's a role for plasmapheresis in patients who need stabilization before thymectomy, in patients who are in crisis, in patients who have moderate to severe myasthenia gravis but not yet in crisis, and those that need a rapid response in the acute setting. In chronic MG, plasmapheresis can be used in a specific case scenario in which patients have been refractory to other therapies. And we've had experience with that. Actually, we reported that several years ago at a meeting in which we had a group of patients, 12 patients, mostly patients with MG, who had been refractory to other immunosuppressive therapies, who we treated with chronic outpatient plasmapheresis, and the morbidity rate was quite low, less than 6%. It was 6% of the patients actually that had dizziness, one of which was associated with nausea. That led to a IV fluid bolus, but plasmapheresis could be resumed either the same day or the next day on those patients. So plasmapheresis in chronic treatment of patients with myasthenia gravis can be done safely in the outpatient setting and can help patients who are refractory to immunosuppressive therapies. There is, however, a subgroup of patients with myasthenia gravis in which plasmapheresis is kind of preferred, and that's the patients who have MuSK-positive myasthenia gravis. This is a small subgroup, perhaps 7% of all myasthenic patients, could be as low as 4% of all myasthenia gravis patients. But in our retrospective case series from 9 US academic centers that we reported a few years back, patients' response rate to IVIG is quite meager. 20% of our patients responded to IVIG, whereas the response to plasmapheresis was around 51% of the cases. Therefore, we feel in that subgroup of patients of MuSK-MG, this is a preferred modality for chronic and even acute treatment. There are clearly patient characteristics, however, that will favor IVIG or plasmapheresis. For example, patients who have either hypotension or sepsis or allergy to albumin, plasmapheresis is not a good idea in those individuals. Similarly, patients who have allergies to IVIG or its components, patients with renal insufficiency, or patients with cardiovascular risk factors are probably not to be placed on intravenous gamma globulins.